Good afternoon, everyone. Thank you for joining today's presentation. I am Crystal Hand, the Director of Three Rivers Area Health Education Center. The team and I are committed to supporting the recruitment efforts, training, education, and retention of healthcare professionals throughout West Central Georgia. And our county consists of 28 counties of the West Central region of the state. I believe we had a picture on one of the slides of our county. Billy, if you could just show that slide so they can get a visual.
Oh, it's the first slide, Billy.
Okay, yeah, there it is there. So those 28 counties there is our region. And we are actually joined today by our dedicated team members who help to implement the programming that helps us execute our mission of building and sustaining a healthcare workforce in Georgia. And just to kind of give you a brief introduction of who they are and what they do, right to left, we have Jennifer Wallace, who handles our daily office operations. Then we have Anita Holt, who accomplishes our K through 12 recruitment activities and initiatives, as well as some of our undergraduate programs. Teresa Williams coordinates the community-based clinical training experiences for the health profession students training in our region, as well as housing and travel accommodations. And then we have Yvette Payton, who handles our RN reentry program and facilitates the continuing education events that we host, such as today's program. Now, we achieve many of our goals through various partnerships, such as the one today. Over the course of the past year, we have encouraged our students and health professionals to expand their knowledge base regarding the emerging health topic of COVID-19. So today's event is a collaborative effort between Three Rivers AHEC, MercyMed of Columbus, and the Department of Public Health. It was important that we include organizations who are out on the front lines administering the COVID-19 vaccine to the individuals of our communities. So it is my absolute pleasure to welcome and introduce Three Rivers AHEC's newest board member, Dr. Asante Hiltz, who is the District Program Manager of West Central Department of Public Health. Dr. Hiltz is here to share some of the most up-to-date information regarding the COVID-19 accessibility in the state. Thank you, Dr. Hiltz, for taking the time out of your busy schedule to meet with us today and to provide a report to the community. And I will pass it on over to you.
Thank you so much, Crystal, and thank you everyone for allowing me to join you all today. We have some good up-to-date information to share with you all. I am excited to say that we have gotten to a place where our vaccine is much more widely available for our community. When we first started, we had a lot of challenges getting access to vaccine enough to meet the demand. And now we finally have gotten to that place where we can meet the demand. So I'm excited to share our new registration process and how you can access vaccine, not only through the health department, but also through other community partners and other vaccine providers. So if you go to the next slide, I'm just going to walk you all through our registration process for COVID-19 vaccine. And that is on our website. It's westcentralhealthdistrict.com. And when you come to westcentralhealthdistrict.com, I've just put up a couple screenshots so that you can see how to get access to the vaccines that we offer at our health departments, at our 16 health departments across West Central Health District, as well as the community sites that we go to. So on this topic of vaccine hesitancy, our goal is to go to recreation centers, senior housing, subsidized housing, faith-based partners, churches, parking lots, homeless shelters, wherever we can, so that we can meet people where they are in case they are unable to get to any of our health departments. So the first step in that process is to go to our page, westcentralhealthdistrict.com, as you're seeing on your screen right now. You're going to click on the link either at the top or bottom. They take you to the same place. And that link says register for COVID-19 vaccine at the top or vaccine registration at the bottom. And if you go to the next slide, it'll show where it'll bring you. It'll bring you to our COVID-19 vaccination appointment scheduling system. This little blue icon that you see asking to proceed to the COVID-19 questionnaire will ask you demographic questions, information about your medical history, information about if you have had a COVID-19 vaccine already, and your contact information. And that will allow you to schedule either your first or your second dose of the Moderna, Pfizer, or Janssen vaccine. And that helps people understand where the closest place is to get a vaccine, if they're looking for a first dose, and if it's their second shot, where they can go to get that second shot. Okay, next slide. On our page, there's also a screen called the COVID-19 information page. And if you click on that page on the next slide, it will show you that we have listed the other places where you can get a vaccine besides us. There's a Georgia vaccine locator. So the yellow arrow shows you that top link, Georgia vaccine locations. Across the state of Georgia, those who have published their vaccine locations, you can click there and identify where else you can go, like a Walgreens or Sam's or CVS. And then under that is the Georgia Emergency Management Agency vaccine site link. That's GEMA. And currently in Columbus, that site is set up at our Civic Center. And they're open Monday through Friday with the Pfizer vaccine. It's a popular location because Pfizer is the only vaccine right now that we can use for our 16 and 17-year-old, those who want that. So if someone wants to use that GEMA site, they will go and schedule an appointment using this link. So those are just some ways that people can find out where they can go. We also have a COVID-19 information hotline that's listed on our website. If someone doesn't have access to this technology and they can't go online and schedule an appointment, they can call our call center. They can also call the library and we can walk them through this process to ensure that they can schedule a vaccine appointment. And that's all that I have.
Thank you, Dr. Hiltz. So we'll pass it over to Billy Holbrook, who will present or introduce our next presenters.
Crystal, thank you. Yeah, so my name is Billy Holbrook. I work at MercyMed. And just a quick shout out to Asante Health's and the team at DPH. I witnessed firsthand a vaccination site they set up on Friday that was just wonderful. Over 700 people got vaccinated on Friday at Cascade Hills of last week. And so that was just a wonderful deal. So I'm so thankful for their work. Up next, a good friend, Peter Huwe, Dr. Peter Huwe from Mercer University is going to take us through, and I'm going to pass it over to you, Peter, as well as Dr. Joyce Kim. And if you'll forgive me the informality, Peter, if you could introduce yourself just briefly, and Joyce, if you'll do the same, and we'll let you take it away. And everybody on the call too, if you'll stay tuned for questions. At the end, we'll be having a real interactive session with Q&A. And so a little later on, I'll invite you to send some questions through the chat. And we'll get to them. So Peter Huwe, if you're there and you can unmute, let's rock and roll.
Sure. Can you hear me okay? Oh, wonderful. Yeah, so I'm Peter Huwe. My PhD is in biochemistry and molecular biophysics from the Perelman School of Medicine at the University of Pennsylvania. Currently, I moved down to Georgia to teach at Mercer School of Medicine. So my background is in teaching medical biochemistry, medical genetics, cancer biology, some immunology, some microbiology, lots of different things kind of thrown in there. And a lot of my research previously had been in looking at different variants in proteins and how that affects the structure and function. So that got me interested in lots of the variants that we see emerging in viruses. Joyce, would you like to introduce yourself?
Sure, thank you. My name is Joyce Kim. I work as a family practice doctor at MercyMed of Columbus. I also serve as the CMO here, and we're just wanting to spread some information in the midst of misinformation, and so Crystal reached out to us, and we're glad to be here just to talk a little bit more. It's our second installment about the COVID vaccine, so hopefully it's educational and helpful. Thanks.
The first talk sort of came about somewhat because Dr. Kim and I were just chatting, and we were talking about lots of different misconceptions that people, even in our own among our own friend groups and family groups, had about vaccines, and we knew that if we saw the need there, then it had to have been broader, and that's what kind of brought about the first talk. And so I really believe that the best way to start off approaching vaccine hesitancy is just to put good information out there. So I'd like to do is just to go over, give you a lot of you probably already know this since many of you have backgrounds in medicine. I'd like to start off with a brief overview of how the mRNA vaccines work, and then we'll talk about the current viral vector vaccines that are in the news right now. And we're going to get through some of the data associated with those. If you go to our previous talk, which can be found online on MercyMed's social media channels, you can find lots of additional information about the mRNA vaccines that we've already covered, and we just won't have time to get to today. All right, so let's talk about start off by talking about the mRNA vaccines. So the way that these are going to work is mRNA is just it's a single-stranded code that encodes for proteins, just a small messenger molecule. And the way that this is going to work is this small sequence of information is going to be encoded in a drop of fat, okay? A lipid nanoparticle specifically. And when these lipid nanoparticles get injected into your arm, this would be the Pfizer or Moderna vaccines, is going to be able to fuse to the membranes of your own cells and dump those mRNA signals into your cells. Okay? And all it is it's just a very, very short-lived signal that tells your cells how to make proteins. Specifically, the kind of protein that your cells are going to be making is a viral protein called the spike protein or the S protein. If you look up here in the top right corner, you can see a computer-generated image of a viral particle of the SARS-CoV-2, and all of those little red things that are sticking out, those are the spike proteins. And those spike proteins are what really allow for the virons to grab onto your cells and pull themselves in so that they can start replicating in you. So the idea is that if we can train your immune system to recognize those spike proteins, make antibodies to cover them up, then hopefully we can prevent those viruses from ever entering your cells. And so the way that this is done, again, is to introduce these mRNA molecules into your cells. That way, some of your cells will start to produce spike proteins. Some of those spike proteins are going to be produced in muscle cells where it's injected, and also interspersed among those muscle cells, there's also going to be dendritic cells, which are a type of innate immune cell. And they're able to take those spike proteins that are made and chop them up into lots of little bitty pieces and carry them all the way over to your lymph nodes and start to present them to other immune cells. And that's going to train your immune cells for how to make antibodies and also T cells, both cytotoxic and helper T cells. And this mRNA signal that gets dumped into your cells, it's, many of you probably have heard this before, but it's not able to alter your DNA at all. Okay? So it's a small signal that just stays in the cytoplasm. It doesn't have any sort of way of actually getting into the nucleus. And even if it did, you don't have another enzyme called integrase, which would be necessary in order to stick a different DNA section into your DNA. So there's zero chance of it altering your DNA. And so far they've been able to work really well. One of the downsides to these vaccines, though, is that mRNA is incredibly unstable, and these lipid nanoparticles that they're packaged in are also somewhat unstable. So these these vaccines have to be kept at very low temperatures, so somewhere between -60 to -80 Fahrenheit, which makes it really difficult to transport them and store them. One of the pluses of that, though, is that once you inject these vaccines into you, that mRNA signal that you're putting in there, that's going to be degraded and over the course of a couple of hours. By the next day, all of that mRNA is going to be gone. So it's a way of really kind of quickly training your immune system to recognize these things. Okay, all right, if we go to the next slide, we're going to, again, you can see here, this is an mRNA vaccine that's coated in this little lipid droplet, fatty droplet. It's injected into your muscles. It's going to fuse to a host cell and allow for its mRNA signal to bind to a ribosome and start making a protein, those spike proteins. All right? Here, when we're talking about the Johnson & Johnson vaccine, we're going to start using a new approach to this. Instead of using these fatty droplets that are carrying an mRNA signal, instead we're going to use a viral particle, an actual inactivated virus, specifically called the AD26 virus, that actually has a small segment of DNA that contains the genetic information, again, to make that spike protein. So here we're really just kind of going one step back in the process. Instead of starting at the mRNA, we're starting at the DNA. So this virus, this inactivated virus that contains this DNA signal, is going to be injected into your cells, or injected into your arm, and then it'll be endocytosed into the cells. And the virus will be able to take its small, short DNA sequence and dump it into your nucleus of some of your cells. From the nucleus, you're able to take that signal and copy it from DNA into RNA, into messenger RNA. And then the messenger RNA is brought back out of the nucleus into the cytoplasm. And now at this point, we're at the exact same point that we were with the messenger RNA vaccines. So we're using mRNA to make spike protein. So really, you're doing almost exactly the same thing. It's just we're using a different way of getting the signal in. Instead of directly dumping the mRNA signal in, we're able to dump the DNA in. And one of the advantages to this is that viruses are really good at getting into cells, and that's what they do. So by using a viral vector, it's really easy to take this DNA signal and DNA sequence and bring it into the cells. Additionally, DNA is much more stable than RNA, which means that we don't have to have it at super cold temperatures. All right? The way that this was actually made is it started off with, again, the virus that they used to make this is an adenovirus. There's a lot of different viruses that can give you a cold, and this is one of those many viruses. So this adenovirus specifically is called AD26, and it can give you a really minor cold. So you get some minor rhinitis, you might get some itchy eyes or a bit of a stuffy nose, and that's about it. It's not very common in the United States, though. If you look in North America, about 10% of North Americans have previously been infected with AD26. So most people have never been infected with this. And in order for this virus to replicate, it requires a certain gene called the E1 gene that you see up at the top right here. So here we're looking at this line with these different blocks represents the DNA sequence of the normal adenovirus, AD26. And what we're doing is we're taking one of these blocks which represents a gene and we're cutting it out and we're replacing it with the gene for the spike protein. So without the E1 gene, this virus can't replicate. That means that this virus, if you get injected with this viral vector now, it's no longer a virus but a viral vector, it can't make you sick. It's unable to replicate in your cells because it lacks the E1 gene. Okay. And also they've cut out a few other genes as well, like the E3 gene, which is related to how it interacts with your immune system, just to make it play a little bit better. All right? Now, we're going to walk quickly through a little bit of the data for how this was set up. Here in the yellow line, we're looking at so this is the clinical trials that were set up for the Johnson & Johnson vaccine. In the yellow column, this is the group that actually received the vaccine. In the green column, this is the placebo group. Overall, they had about 43,000 participants. Okay? And the thing that I want to point out to you in this table is that they did a really good job of making sure that the vaccinated group, the people who really got the vaccine, really looked a lot like the group that had the placebos. So if you look at the age ranges, so 18 to 59 years old, there were about 14,500 people who got the vaccine, 14,500 people that got the placebo. Okay? Same thing for ages 75 and over. There were 800 versus 723. So what this means is that when you look at how the trials were set up, they didn't have lots of old people on one side and lots of young, healthy people on the other. Okay? Same thing with races. Okay? If you look at the races that were included, it's an even split among the placebo versus the vaccinated groups. Okay? Also, the absolute numbers of the races that were included in this roughly reflect the demographic breakdown of America. So there were, if you look at the within the clinical trial, 58.7% of the participants were white, 19.4% of the participants were Black or African. About 9.5% of the participants were American Indian or Alaska Native, which is higher than what we have in the United States. One of the smaller groups here is the Asian population is only 3.3%, but they did a pretty good job of having people from lots of different demographic groups included in this. And again, they were split evenly among the vaccinated group versus the placebo group. All right. If we also then look at a few other things, this particular vaccine trial was actually conducted in multiple countries. It wasn't just the United States. They also looked at, so there were about 19,000 participants in the United States, but we also had 6,500 participants in South Africa. We had 17,900 participants that were from Latin America. So it was kind of nice that they were able to spread it out across the world, and that allowed for this particular vaccine trial to include lots of different variants of concern that are currently in different parts of the world. All right. Another thing that they looked at when they included, when they were bringing participants into the trial, is they wanted to see, well, how many of these participants maybe have already been pre-infected with COVID. Okay? Because again, if you had one group that had lots and lots of people that had already been infected with COVID and already had antibodies, then that could skew off the results. So where you see the positive number, these are the individuals who tested positive for COVID antibodies before they started the clinical trial. So in the vaccinated group, again, there were about 2,000, and in the placebo group, there were about 2,000. And so the people, among the people who were tested negative, that means that they hadn't previously been exposed to COVID, that's about 19,000 in both groups. Again, one of the nice things about this is it's building in a test or another test into the trial to see, is it okay to give the vaccine to people who have previously been infected with COVID? And or do they have nasty side effects? And so it's kind of nice that that was already built into the study, allowing us to know that it's okay to give this vaccine to, or is it okay to give the vaccine to people who have already been exposed to COVID? All right. Another thing to consider is the presence of comorbidities. So again, if you look at the vaccinated group versus the placebo group, there's a pretty even split. So about half of all the participants in this trial had some sort of comorbidity. And again, it's pretty evenly split between the vaccinated group and the unvaccinated and the placebo group. All right. If we look at the actual comorbidities that are present, let's say obesity, for instance, again, you can see that within any particular comorbidity is pretty evenly split among the vaccinated group versus the placebo group. So again, you don't have lots of obese people on one side in the vaccinated group and all skinny people in the placebo group, or vice versa, or lots of people with type 2 diabetes in the placebo group and people without type 2 diabetes in the vaccinated group. Again, for all of these different comorbidities, there's a pretty even split among the placebo group versus the vaccinated group. And again, the reason why I'm bringing up all this data is just to show that I think they did a really good job in the way that they conducted this clinical trial. They controlled for lots and lots of different possible sources of variation. All right. So now if we actually look at some of the data, this type of graph that we're looking at here is called, this particular graph is looking on the x-axis at the time since the first dose, and in the y-axis on the cumulative incidence. So this is called the Kaplan-Meier curve. And all that we're seeing is is anytime so at time 0, that's when the first shot was given, and then we're seeing, does someone test positive for moderate to severe COVID? If they do, then you see the line go up. Okay? The reddish brown line, that's going to be the placebo group, and the blue line is the vaccinated group. Okay? And what you'll notice is that if you look between day 0 to day 14 that I've shaded in yellow here, these two lines are almost exactly the same. Okay? What that's saying is that if you were to get a vaccine, your first dose of this Johnson & Johnson vaccine, for the first 2 weeks, your protection against the virus is no different than anyone else. Okay? It's as if you hadn't ever gotten the vaccine for the first 2 weeks, because it takes time for your immune system to train itself on how to recognize the virus. Okay? Once you get beyond day 14, you notice that these two lines start to diverge pretty widely. You see a small gap between days 14 to 21 and then 28. After day 28, though, you really start to see them spreading apart. And you see way more infections in the placebo arm than you see in the vaccination arm, which is good. And for all of these patients, they monitored all of them at least 56 days out. Some of them they monitored even farther, all the way out to 126 days. So what this is showing is that we actually have pretty good efficacy against moderate to severe COVID compared to placebo. All right? If we dig into some of the actual numbers, you'll see that if we're looking just at incidence of the or protection after 28 days after the vaccination, there's about a 66% efficacy in the Johnson & Johnson vaccine for moderate to severe or critical disease. And the individual numbers differ a little bit depending on which country the clinical trials were run in. So you'll notice that in South Africa that our numbers are a little bit lower. We're at about 64% efficacy. If we look at the United States, after 28 days, we're at about 72% efficacy. This is likely due to the presence of more virulent strands of the virus in South Africa and Brazil than what we have in the United States. So in the United States, again, the dominant variants that we have here right now don't spread quite as easily as some of the variants that you see in Brazil and South Africa. All right? If we look at the very, very worst outcomes of COVID, so meaning deaths and or hospitalization that requires ventilation or being admitted to the ICU, this trial showed that the J&J vaccine does a really good job. So out of all those 40,000 trial participants, there were 7 individuals who ended up dying from COVID. And all those individuals who died of COVID were in the placebo arm of the trial. So no one who actually received the vaccine died from COVID. If you look at the ages, so the age range for these patients is between 49 to 68 years old, and all of them had some sort of comorbidity. Most of them had obesity, one of them had asthma, and some of them had additional comorbidities as well. So what this is suggesting is that, at least based on this data set, the clinical trials look to be roughly 100% effective at preventing death or hospitalization, including ICU admission and ventilation. That said, those numbers could change over the time, because here we're looking at 40,000 participants. If we were instead looking at 40 million, you might see that 1 or 2 people slip through the cracks and die. And only time will tell with that. All right? I think it's worth also addressing vaccine immunogenicity. And what I mean by immunogenicity is the vaccine's ability to elicit an immune response within you. Okay? So once you get the vaccine, what are the changes that actually happen to your immune system? And one of the nice things is that a single shot of the J&J vaccine is able to allow you to have neutralizing antibodies. These are able to bind to that spike protein and hopefully prevent it from ever entering cells. But also, in addition to that, it's also able to elicit a strong CD4 positive and CD8 positive T cell response. So CD8 positive T cells are these cytotoxic T cells, sometimes called killer T cells. And CD4 positive T cells are what we call helper T cells. And if you look at helper T cells, there's several different classes of them. And here the class that's actually activated in these patients are Th1 helper cells, which is exactly what you would want to have in response to a viral infection. So this is going to be, the Th2 is associated with something that some of you might have heard about, which is antibody-dependent enhancement. And so this should not elicit any antibody-dependent enhancement. Instead, it's just going to help to promote your own body's ability to have a lasting immune defense against the disease. The neutralizing antibody response, we know, lasted at least 85 days in all age groups from the clinical trials. And if you were to look at some other trials that were done, so they did some trials in non-human primates, there we go, chimpanzees. They saw that if you gave a second dose of the vaccine to chimps, then the number of neutralizing antibodies went up by about 2.5-fold to 3-fold. The same thing's true in the phase 1 and 2A clinical trials that were run. If you gave a second dose to the patients 56 days later, you saw about a 2.5-fold increase in the neutralizing antibodies. And so the question that still remains is, does this increase in the level of antibodies actually cause you to have increased protection? Because again, there's roughly 66% protection against getting sick from COVID. If you got another dose of the vaccine, of the J&J vaccine, could that increase it? And there's currently clinical trials that are going on right now that are trying to assess that exact question. And so we don't quite know the answer yet, but I think it's probably going to be likely. If we were to compare this to some of the mRNA vaccines, the mRNA vaccines do a decent job after the first dose of starting to allow you to have a neutralizing antibody response. But it's not until after a couple of weeks after the second dose that you really start to see the CD4 positive and CD8 positive T cell numbers go up, and you see a big jump in the neutralizing antibodies as well. So it's thought that it's probably because DNA is more stable than messenger RNA. That's probably part of the reason why a single dose of this seems to be do better than a single dose of the messenger RNA vaccines. But again, we'll just have to wait and see if 2 doses of the DNA vaccines are even better than 1. Right? So now I'll turn it over to Dr. Kim.
Thanks so much, Peter.
Hey,
Oh, sorry.
hey, I'm so sorry to interrupt.
Oh, no problem.
This is Billy. So folks, I do see a question in the Q&A side of this, and I was going to recommend is, as you do have questions, if you would be willing to put them in the chat function as we go, and we'll address those after Dr. Kim's section. I can't, for some reason, I can't pull down that question in the Q&A, and I want to make sure that we get all that stuff addressed as needed. But if you would, as you have questions, you can either send those questions directly to me, or you can put them in the chat for the whole group. And as we can, once Dr. Kim's piece is done, we'll address them. So thanks, a little housekeeping. Sorry, Joyce, back to you.
No problem. So I was going to delve a little bit more into the update on the mRNA vaccines. They were officially approved mid-December, the both of them, and so there's been some updated data. Some of it is through the CDC, and some of it is just independent researchers who have published their own data. So most of the information that I have is from the CDC. They did actually have a webinar that went over a lot of the safety data. Unfortunately, it hasn't been updated in some time, so I'm going to share what we know. Thankfully, most of the data is consistent with what we originally saw in their phase 3 studies. So I just wanted to thank the CDC for the work they do and for giving us information. So I wanted to talk a little bit about Vsafe. It's an app, a phone app that was developed specifically for the COVID-19 vaccine by the CDC. So it's meant for anyone that has received the vaccine. It's very, they pursue you. So they text you every day of the first week, and then weekly through week 6, and then every 3 months until 1 year is up. And there are pre-populated symptoms that they're looking for. So if you click no to all of those things, then that's fine. If you happen to discuss that you've had a side effect that required some sort of medical intervention, then you'd receive a call. And so they reach out to you to find out what happened. So again, it's a way to report side effects. It's not necessarily a way to assess causality or trace it back specifically to the vaccine, but a way to gather information. So I did want to mention if you do not register as a male, then I think they automatically ask if you're pregnant, and if you are, they have a special team that reaches out specifically to pregnant moms, and so we'll be coming back to that. Next slide. So through the Vsafe data, there was a MMWR publication from the CDC that went through information collected from the time of the rollout to January 13th. So that covered the first dose of the Pfizer vaccine, the second dose of the Pfizer vaccine, and the first dose of the Moderna, just the way the dates lined up. So if you look, the first graph describes the side effects that patients experienced after the first dose of Pfizer, and the third graph describes what patients experienced after their first dose of Moderna, and those bar graphs look really similar. So that's their side effects throughout the week, and it looks like most of the side effects were experienced during days 1, 2, and 3 after the vaccine, and the most common one, that tallest dark blue block, is injection site pain. And then if you look at Pfizer dose number 2, which is that middle graph, it does look like consistent with what they found in the studies and probably what you've been experiencing or hearing from your friends. The second dose of the Pfizer stimulated more reactogenicity, just meaning that at that area where you had the injection, you had more pain, and you also experienced more fatigue, headache, muscle aches, and chills. So the data that they collected was from way more patients than were involved in the studies, but were consistent with it. So if you look, it's about 750,000 for the first dose of Pfizer, and about the same for the first dose of Moderna, whereas the studies had 40,000 for Pfizer and a little less for Moderna. Yeah, if we go to the next slide, it goes through some of the same information, but just in a different format. So again, dose 1, day 1 seems to be the highest reactogenicity for both of the vaccines. And then for comparison's sake, we can compare it to how the Johnson & Johnson did. So if you click forward, Billy, there's an extra table in there that just compares, the reactions that people had between the Pfizer and the Moderna, which again, we have a lot more information about those two, and then versus the J&J vaccine from their phase 3 trial. So a little less injection site pain, and a little more fatigue and headache, nausea, muscle aches, both comparable for fever. So just to kind of realize, I guess, for all of us, if you're in the healthcare field or if you're having conversations with friends, I always think it's helpful to know what to expect, and then it builds a level of trust to say, oh yeah, they told me to expect this, so I won't have to be worried when my arm is red or it feels swollen or it's really painful even 3 days after I've gotten the vaccine. It's reassuring, I think, for patients, and builds a level of trust between healthcare professionals and their patients, and and just in general the population to be more open to receiving the vaccine. And I think this is pretty common knowledge at this point. Everyone is expecting these side effects, and nothing out of left field that they're finding from the Vsafe data that's being reported. So that's reassuring. Go to the next slide. Oh, sorry, we can go on. The other way that the CDC collects data is through the VAERS system, so Vaccine Adverse Reporting System. This has been around for a long time. It's not specific to the COVID vaccine, and it's user dependent. So you have to go in and report an adverse event. Either the clinician can or the patient can. This information is actually available to the public, so you can look up what are the reactions that people are reporting to the COVID-19 vaccine. It's dangerous again because there's sometimes there's influencers who will take the data and interpret it incorrectly. And I always like to think about, if I were driving a Camry and I got into an accident, it would be really dangerous to assume that it was the Camry. It could have been, I could have been a distracted driver. There could have been a distracted driver on the road, or there was something there. The weather conditions were horrible. So the reporting is there, and they use it so that they can figure out what's statistically significant. So it's good, and then the fact that it's publicly available is also good, I think. But I just want to throw out that caveat to remember that there are ways to analyze data that will make it so that the bias is pushed out of it, and we can actually assess cause. It's actually very difficult to do, but thankfully there are people much smarter than myself who understand statistical algorithms to be able to do that for us. So if you go on to the next slide, they they've received about 105,000 reports of adverse events, and this is data through February 16th. So again, this was through about February 16th. Sorry, I'm going to refer to my notes. There were about 52 million doses of the vaccines that were given. So 105,000 reactions is pretty low for 52 million doses that have been given. Of those, 94% were considered non-serious, and that's in line with what you see with, for example, the flu vaccine, and 6% were considered serious adverse events. The 94% are going to be the things that we already talked about, like injection site pain and swelling, redness, headache, fever, muscle aches, things like that. The serious adverse events, if you can go forward, Billy, probably the most serious that we're all thinking about is death. So there was a report through mid-January from the VAERS report that calculated the deaths. There were 113 deaths. This is also in that MMWR publication that came out at the beginning of March. So it states that 35 deaths were in non-long-term care facility residents, and 78 deaths were in long-term care facility residents, of whom 42 were either enrolled in hospice or were considered a do not resuscitate status, meaning if something were to happen that were life-threatening, the patient did not want any type of life-saving maneuvers to be performed for them. So the majority of the deaths were in our frailer, older population, and even within that population, the majority did not actually want any type of invasive measures to help, and they wanted to, just have their wishes respected. So the causation, again, as we talk about, was it the vaccine that caused the death? it doesn't seem like it's statistically significant enough to be able to point to that the background rate of death in the populations that we're looking at coincide with what we're seeing in the VAERS reports. The other major reaction that's been seen on the news and things like that is anaphylaxis, which is just an overdrive of your immune response and causing an allergic reaction. If you can go to the next slide, Billy, there was a report that came out in JAMA that looked at the number of cases of anaphylaxis. There is about 4.7 per million doses of the Pfizer and about 2.5 per million doses of the Moderna. And again, that's pretty consistent with other vaccines that we see on the market. So it's not surprising. I suppose it's expected to see that. And thankfully, anaphylaxis is one of those conditions where when we do administer the vaccine properly and monitor the patient for 15 to 30 minutes afterwards and have EpiPens available and the correct steps in place, it's treatable, and no one has actually died from these anaphylaxis events. So moving forward. So I did want to come back to the pregnancy data that they've been able to gather through the Vsafe mechanism. This is really interesting because in the studies, they excluded pregnant women because of safety concerns. And so now we're gathering data from millions of people who have received it. And of those millions that reported in Vsafe, there are a total of 30,000 that have been pregnant who received the vaccine. There's probably, way more, but that's all that was reported through this cell phone-based app. And about half and half for Pfizer and Moderna. So the reactions from these, from the women that did respond is reassuring as well. So if you compare non-pregnant to pregnant females, on the left side of the screen is going to be for local reactions. So it says here pain and swelling, redness, and itching. And similar to what we'd seen before, it just seems that the first dose does a little bit more, and the first dose responses are fairly similar between Pfizer and Moderna, and same with the second dose. And then the right side of the screen goes through more systemic reactions, and these are both just day one after the vaccine. And if you compare the orange to the blue, the orange being not pregnant and the blue being pregnant, those rates are pretty similar, and you might argue that pregnant females had less of a response as well. So thankfully, it looks like pregnant females are responding the way that we would expect non-pregnant females to respond to the vaccine as far as local reactogenicity goes. If you go to the next slide. So of the women that reported that they were pregnant, it looks like Vsafe reached out and enrolled about less than 2,000 women to be part of the long-term pregnancy database. So if you go to the next slide, there have been data collected of the 1,800 women that were pregnant, 275 have delivered at this point. And so they collected data on the pregnancy outcome, on pregnancy complications during the pregnancy, and then even after the pregnancy, what the neonatal outcomes were. Again, so this is not from all 30,000 that reported they were pregnant, but just from the 1,800 that were enrolled. And again, thankfully, the rates of these sort of scary complications we think about with pregnancy were similar to background rates in the population that you would expect. So, and you can read through that. I think the slides will be available afterwards, but just as sort of a general reassurance measure. It looked like these complications were similar in just background rates and also in women who had been vaccinated. To the next slide. So VAERS, I've been skipping back and forth between Vsafe and VAERS, but in VAERS, there were 154 women who reported adverse events who were pregnant. And again, you see most of the adverse events that were reported at the very bottom of that table were non-pregnancy specific adverse events. So about 73% were local reactogenicity reactions that we talked about. And then about 27% were actually pregnancy and neonatal specific conditions. So the largest number you see on there is spontaneous abortion and miscarriages. And there's baseline data that's collected through the American College of Gynecology. And on the side there, it's sort of the caveat for stillbirths. It gives us the breakdown where between 20 and 30 years of age, you would expect early pregnancy loss of 9 to 17%. Age 30 is 20%, age 40 is 40%, age 45 is 80%. So if you go ahead and take the average of that, 29% it looks scary, but it's actually similar to what you would expect from your general population as well. So, the last sort of portion that I wanted to talk about in terms of pregnancy is also in lactation. There is a small study done that included 131 women, 84 of whom were pregnant, 31 were lactating, and 16 were not pregnant. And it did show that there was a good, robust immune response in terms of antibody levels that were developed in the pregnant females. And of the 13 that delivered during the study, they were able to test the cord blood in 10 of those patients, and there were circulating antibody levels in the cord blood as well. And so if we start to delve into topics like transferring immunity to the neonate, that can actually be fairly reassuring to know that if moms are vaccinated, all of these women were vaccinated in the 3rd trimester who delivered, but that they might be able to pass on the antibody response that they have to their children as well through the placenta and possibly through breast milk as well. So can go to the next slide. Yes, okay. So I'm shifting the conversation a little bit. So that was updates on safety of the mRNA vaccines. This is a small update on the efficacy as well of the vaccines. So there's a term in vivo and in vitro. There's sort of a lab setting where we can control everything and measure outcomes, and then there's a real world setting where we can't control everything, but how does this vaccine work in the real world setting? There are lots of studies out there. I've included just a handful. The first two, the first one is another MMWR report. The second is a preprint, and the third is actually a press release, which I don't really like to go to for information, but it seemed really relevant, so I included it, and hopefully they'll be submitting their data for peer review pretty soon. But so basically all of this is to say that data that's been collected from the real world setting in terms of efficacy of the vaccine have been very consistent with what they found in the studies. So for Pfizer and Moderna, they both reported an efficacy rate of greater than 94%. And in the real world setting, it looks like at least 14 days after the second dose, you're going to have greater than 90% efficacy. That's what the MMWR found. And in the study at Mayo Clinic, they had about 89% efficacy. And then what's interesting about the Pfizer press release is that It's compiling data from the beginning of their phase 3 trial to 6 months afterwards. So we don't have a lot of data that looks at patients who have been vaccinated, for that long yet. And so their data was exciting that even from September to March, they're still finding that the efficacy of the vaccine is good, and it's at 92%. Again, this is their press release, so, with a grain of salt. But yeah, and they report 0 cases of severe disease in the vaccinated individuals, which is what we're really wanting to avoid, is the catastrophic events from COVID. So I'm going to hand it back over to Dr. Huwe.
So I think you've all heard about different variants of concern in the news a little bit, so I want to address that to some extent and let you know what exactly we're talking about here. So when we talk about these different variants, what we're saying is that within especially the spike protein is kind of the one that we're most interested in, there's been some sort of change. Okay, so a particular protein, if we look at any particular protein, it's made up of little building blocks called amino acids. Okay, so let's just, if we were to go all the way back, rewind to where we had the messenger RNA, 3 letters of messenger RNA is enough to spell out 1 amino acid. So let's pretend that the protein was it's like a charm bracelet with different charms on it that could fold up in some unique conformation. And the messenger RNA might say CAT, and the first charm dangling from the bracelet is a cat. Next one is BAT, so then you have a little back charm hanging from it. Okay, so all these different charms are on this long string, and they can fold up into a particular conformation, and that makes the protein. Okay, so each of those charms is an amino acid. And so what we're looking at here when we talk about different variants of concern, there's different amino acids that are present in different ones. So maybe one of the cats on that charm bracelet got substituted for a bat or a turtle or something else. The very first virus that actually came to the United States from China was itself a variant. It's called the D614G variant. And all that means is that, again, if you were to look at the bracelet and count the different charms along it, charm number 614, it started off, in its original thing was a D, which is an aspartic acid. And here, the one that we actually got was, instead of it being an aspartic acid there's a glycine, which is a different amino acid. So it's just a little shorthand code that biochemists use to say, what's the actual physical change that's happening? Okay. So we started off with a variant here, and if you look at all the vaccines that were developed, they were developed for this D614G variant. Now, unfortunately, since then, there have been a number of different new mutations that popped up in different parts of the world. So one of the ones that you've heard about is the UK variant, also called B117. Okay. This has 18 different mutations present in the virus, and among those 18 different mutations, one of them in particular is on the spike protein, and that is an N501Y mutation. So that means that, again, if you were to count all of the amino acids, at position 501, there used to be an asparagine, and now there's a tyrosine. That's all that they're saying. So we've swapped one out for another. If we look at the South African variant, okay, there's 8 different characteristic mutations there. South African variant is also called B1351, and that has 3 different mutations that are present in the spike protein. You see the same N501Y mutation, and plus 2 others. You see this E484K, so that means that there used to be a glutamic acid at position 484, and now it's switched to a lysine. And K417N, that means there used to be a lysine at position 417, and we switched that to an asparagine. Okay? So again, the virus has swapped out one amino acid for another. If we look at the P1 variant, that's the Brazilian variant. There's 28 different characteristic mutations. Among those on the spike protein, there's an N501Y mutation and an E484K mutation. Now, the reason why these are important is that the way that your antibodies work is they are looking for particular regions on the spike protein to bind to. Okay? So let's say that your body is the spike protein, okay, and your hand is normally where the antibody fits like a glove. So you've got a glove that fits right on top of your hand. It's able to cover up your hand so your hand can't ever touch anything. Okay? If you were to mutate your pinky into another thumb, that glove might not fit on quite so well. Okay? And so that's one of the issues that's happening in some of these variants. So if you look at the B117 mutation variant, the UK variant, this one tends to spread a little bit faster and be a little bit more infectious than the variant that we have in the United States, or used to have as a predominant thing in the United States, the D614G mutation. But our amino acid, or sorry, our antibodies still actually bind really well to that. Okay? But if we go down to the B1351 variant, or the P1 variant, that's the South African one and the Brazilian ones, these two both spread better than the original variant that came to the United States. And also, we have reduced antibody binding. Okay? And the reason that we know this is it's a fairly simple experiment. All they do is they take the blood from somebody, a little sample of blood. I'm simplifying this a little bit, but they take a sample of blood from someone who has been vaccinated, okay? And then they add virus to that, and they see, do the antibodies that are present in that person's blood bind to the virus? And if they do, they can measure how much they bind to it, and that's how we know how well these antibodies are still binding. Now, if you received one of the mRNA vaccines, you do still have antibodies that bind to the South African and the Brazilian variant, but it's a decreased amount. That said, it's still likely to be protective against severe disease. Okay? So it might be that it might not be sufficient to protect you at the 95% efficacy level for all disease, but it's still thought to likely protect you against severe disease. Additionally, even though the antibodies don't bind so well, we don't know yet if this is going to reduce the efficacy of your T cells, those CD4 positive and CD8 positive T cells. So those memory cells are likely to still be able to have a good effect on these. We don't know for sure, but it's likely to still have a good effect. So to kind of sum all of that up, the B117, the UK variant, that's the one that's predicted to be the one that kind of overtakes the infections in the United States first. And that one, all of our vaccines should work really well against. These other two variants are present in the United States right now, and the vaccines are likely to not work quite so well against them. But they are still likely to prevent you from getting really, really sick. There's lots of other variants that do exist out there. One of the ones that's also kind of sweeping a little bit faster across the United States there's two different Californian variants. For both of those, the vaccines, we believe, are going to work well against them because, again, if you do that little blood study, the antibodies bind really, really well to it. So we're not too worried about those escaping the vaccines. The biggest two right now that we're worried about are the South African and Brazilian variants, but again, we suspect that the vaccines are going to be sufficient to prevent severe disease. It will be possible for pharmaceutical companies to just make some additional vaccines that include, so it might be a booster shot, and we can get into this a little bit later on, a booster shot that includes these mutations, and that way you could train your immune system to recognize those mutations, and hopefully it should bind to it just fine and be able to take care of it. But we can get into that a little bit later in some of the Q&A stuff. Okay. And so we have some references, and Billy, we'll let you talk now. You can walk us through any questions that we've received.
Cool deal. Thank you, guys. So I am grateful for Crystal and for Yvette for fostering a lot of questions in advance, and so we're going to get to those now. That's kind of how we'll start the Q&A time. We've gotten some questions through a Google form that was created by Three Rivers AHEC. And so we'll start there as we progress on the slides. But to everybody on the call, if there is a particular matter that you'd like Dr. Kim and Dr. Huwe to refer back to and provide more clarification, please send that through in the chat. If there's a new topic that hasn't been discussed yet, please send that through in the chat. And once we kind of get through the prepared question and answer time, we will do that as well. And Dr. Hiltz, I don't know if you're still on the call, but if you are, please chime in at any point, and we'd love to get your perspective. Hey, there you are. Cool. All right, so let's go. So the first question, I don't know who wants to talk through this one. I saw Joyce looking at this website yesterday, which is really exciting. And Asante, you might want to share a little bit as well. But the first question, how many people in our area have been vaccinated so far?
Yeah, I'd be happy to take this on. And Dr. Hiltz, any input you have is so valuable because you see it from the bird's eye perspective. But the Georgia DPH has a really cool site, not only for vaccination data, but also for COVID data. And there's a screenshot from that we'll get to later as well. But it does update pretty consistently. This is a screenshot from yesterday, and it'll collect data for the number of people, sorry, I kept trying to say patients, people that have been vaccinated, and it looks like there's about 50,000. Not all of those are Muskogee County residents. So you see on the bottom, that blue number, residents vaccinated, is 31,000 who have received their first dose. So at least one dose is 16%. So we're definitely wanting to bring that number up, but I know there are lots of efforts going on in town to do that. What I found interesting was on the right side of the screen, in that top box, you see a pie graph and then a bar graph right below it. There are different tabs that you can walk through, and it'll differentiate based on different demographic data, so by sex or age or race or ethnicity. And I think there was a specific question later that we'll get to that asked specifically about vaccine hesitancy in African Americans. And so I just thought I'd address this little box here. It looks like in Muskogee County, we have had about 11,000 African Americans vaccinated, about 15,000 whites vaccinated, and about 73 American Indian or Alaska Native. So if you look at the pie chart, it just shows the breakdown of where the vaccines are going. So about half to whites and about, what would you say, 40% or so to blacks, and the remainder to those other groups. If you look at the census data from 2019 for Muskogee County, it's a little bit more halfway. About 48% are considered black in Muskogee County, and about the same number, 48%, are considered white in Muskogee County. And so it's a little bit of a discrepancy, but I was hopeful looking at that graph. Also, along the bottom, the bar graph shows the percentage of each population that's been vaccinated. So about 9% of the American Indian population has, about 12% of the black population has, about 17% of the white population, 16% of other, and about 20% of the Asian population has. So again, it's not even by any means, but reassuring, and I think we're moving in the right direction on that. So yeah, if you want more updated information, the DPH does a really good job updating that data, and it's just fun to sort of watch the trends and see where the concerns are.
Thank you, Joyce. Dr. Hiltz, anything to add to this slide?
I don't have anything to add. Dr. Kim covered it well.
I do have a question that's a little bit of a follow-up to you that I'm just curious about. You and I talked on Friday about, we're kind of at the point where there are more vaccines and people who are willing to get vaccinated. And so I think in general, there's kind of a slowdown. Is that fair to say? A slowdown of folks getting vaccinated? And if so, what's the next step, 2 months from now, 6 months from now, in terms of where the need would be in terms of focusing energy? Is there a need to, because I know it's super accessible to get the vaccine, but in terms of, who else needs it? Are there more from a certain population you think that need to be, I guess, a campaign for to try to get them vaccinated? What's your thoughts on getting the shots in arms, that where they need to go?
Well, I have two thoughts on that. The first one is in terms of accessibility. I think that having more opportunities during non-working hours would probably accommodate people better, because what's reflected here on the screen is most likely going to be agencies like ours who work predominantly 8 to 4 and 9 to 5 during the day when people are working. We do some Saturdays, but not at the same level as the weekdays. And that may be a challenge for some people who don't have the flexibility to leave work to come get a vaccine. So maybe focusing on some more after hours weekends may allow people to have more accessibility. Going to where people are, which is one of our strategies, instead of letting people come to a clinic, going to a particular community site, into neighborhoods, into housing complexes. Those things may make it easier to get the vaccine. And then my second thought is what is not as reflected well on here is ethnicity with Hispanic, non-Hispanic, because even with testing, we tried to focus some attention on our Hispanic communities more because we didn't see them getting tested as much. And I think that's the same here with vaccinations. We aren't seeing, coming through our clinics at least, the same number of Hispanic population. So we want to focus some more attention in those groups.
Dr. Holtz, there was a question that came in, and I'm not sure if you're privy to this, but anonymous attendee asks, does the vaccine distribution dashboard include military retirees vaccinated through the VA or Martin Army Hospital? Do you know about that?
It's not going to include the federal VA or the Fort Benning. So those numbers may not be shown here.
Okay, got it. Thank you.
Cool. So related, this question here, how do we address the mistrust that some members of the Black community feel towards vaccines and medical care as a result of historical mistreatment? And please address the role of peers in alleviating vaccine hesitancy. So I'll put that to the panel. If anyone might want to, I'll just kind of open up the floor to the panel for anybody that might have some thoughts on this particular slide.
Yeah, I'll start with the second. I was just thinking today about how much anecdotes empower us and influence us. I think I had a patient today say that she started using a new mascara because her influencer talked about it. And I can understand that. We're inundated with a lot of opinions and stories. But I think a story is really powerful. And so the role of peers in alleviating vaccine hesitancy, I think especially in the medical field, it's sometimes surprising, but maybe not so, when we see that a third of the population in hospital staffing don't want to receive the vaccine. And that's not to say that we're on a crusade to convert everybody, but I think sharing your story can be really powerful, and hopefully this type of exercise and activity is helpful as well to equip us with the information. I will say in the room, one of the more common questions I've been getting now is, what do you think about the vaccine? And while it's not a peer-to-peer relationship, it's still, I'd say we're on equal footing when it comes to something as new as this. And when I share honestly about the data and how convincing it is, and that we've read through the fine print and it looks like it really is effective, that they're not making up these numbers. They can't. There's just too much data out there now, and it looks really good. For the most part, it does help, I think, to alleviate some of that hesitancy that that I expect patients to have.
I think there's a particular challenge that's going to be hard to, that kind of underlines this, that's hard to address, and that's that there's a, the Black population is really underrepresented among medical doctors and DOs, and so a lot of times individuals in particular communities, they don't have as many voices that are saying, yes, I give this to my patients. And I think that might make a difference. And again, that a lot of those discrepancies are due to historic racism. And so when you're in a pandemic, it's hard to say, how to say this? We've got this problem that exists from hundreds and hundreds of years of racism. And so it's hard to turn around and say, okay, we're going to fix this in a week and just erase all those bad things. I think that one of the approaches that can be done perhaps is to reach out to community leaders in the Black community who are trusted in the communities, whether it's pastors, leaders in the mosque, other community leaders, etc. And I think it's important for scientists and doctors to educate some of those community leaders on what we talked about today. How were these actual vaccine trials run? Was there equity among different races? Because really, I think especially when you look at the impact of COVID on different populations, a lot of our minority populations were particularly hard hit. And I think that these vaccines can be a really, really good thing in helping to protect some of those vulnerable populations. We just have to figure out how to address the hesitancy along the way.
Awesome. Thank you, guys. Any other thoughts on that before we move on to the next one? All right. So what's it looking like today? What are the current COVID numbers looking like? And how has vaccination helped bring numbers down? I'm a layperson, but I can tell you this is a heartbeat on this slide. It looks good. Joyce, am I right about that? That's a heartbeat, right? That's a QR wave or something? Did I get that right?
So close.
It might be something else. Go ahead.
I love it. It's the heartbeat of Muskogee County in terms of COVID numbers. You had it right on the money. Yeah. So this is also a screenshot from the DPH's website, again, from their dashboard for COVID incidents. And so if you see here, it's really neat because they give you the day-to-day numbers and then also the 7-day moving average, which is helpful. And I hovered on this screenshot over April 2nd. Just to sort of give us a context, and it looked like the confirmed number of cases was 31 and the 7-day moving average was 22.9. So I'm sorry, did I say, I think it's 31, sorry. So numbers have definitely come down since the spike in January and in July. I think it's a little bit early, honestly, to say that it's really from the vaccine. It's warmer now, so we know that the numbers are going to go down. We know that more people have just had it at this point, and so there's a little bit of that immunity that's developing, and hopefully less surges of cases. It's not, again, I don't think it's any one thing. It's probably the combination of all of those things, that it is warmer weather, that people are have had COVID, and they've also received the vaccine. So, but this is a neat interactive dashboard that you can look back to every day they update it.
Is it too soon to be encouraged by this, Joyce? How should we feel about this slide?
I personally think it's too soon because we haven't reached a number of vaccinated individuals. And so there's innate immunity just from having had the disease and having developed your own antibodies versus developing antibodies through the vaccines. And we're not at the number yet to be able to say we have something called herd immunity, which we didn't really talk about very much. But in short, I think it's a little bit early. It's nice, but I don't think we can bank on this, riding out into the winter time if vaccinations don't continue to go up.
Okay. Next question.
This is just a continuation of that similar data. This is looking instead at the whole nation, and you can see, we did have on the bottom left there some the green line, the blue line is new cases, the red line is new deaths, and the yellow line is the trend line for currently hospitalized people. And you can see that from the winter nationwide, we're definitely going down a lot, but over the past couple of weeks, for all of these numbers, especially the hospitalizations, the new cases, we've really kind of plateaued. So I think it's hopeful that the numbers are lower than what they were, and it's certainly hopeful that we don't have as many deaths per day as we previously did. But I think that we're not out of the woods yet, because just like Joyce said, we're still far away from herd immunity.
All right, we'll move on to the next question. Are there fetal cells in the J&J vaccine?
That's an interesting question. You could ask a similar question about the AstraZeneca vaccine that's not made here. But Billy, if you can go on to the next slide, we'll go back to and click one more time. You'll recall that I mentioned that in order for these viral vectors to grow, in order for them to replicate, they need that E1 gene, right? That E1 gene has to be present in order for viruses particular viruses, the AD26 virus, to grow. And they've removed the E1 gene from it. So in order for you to grow all these viral vectors, you actually have to grow them in cells that have the E1 gene. Now, most of your cells do not have it, and most cell lines don't. But there are a few cell lines that do have it, and some of those cell lines were derived from fetal or embryonic cells. So if you look at the AstraZeneca vaccine, so the one that it's not approved here yet, that uses HEK 293 cells. So HEK stands for human embryonic kidney cell lines. And this was actually, those cells were originally taken from, it was a Dutch experiment where they harvested these cells back in 1973, I think it was. And back then in 1973, in the Netherlands, they didn't allow for any electoral abortions unless the mother's life was at risk. So for that particular cell line, the HEK 293, we don't know if those cells came from a spontaneous miscarriage or if it was from an elective abortion due to it putting the mother's life at risk. But it was one of those two scenarios. Again, it's all anonymized data, so we don't know for sure. But anyway, that same cell line, they were able to tweak it and have those same cells that they took from the kidney line of that fetus and have it manipulated so that it would grow over and over and over and over and over again, right? So imagine that you plucked one of the hairs from your head and you're able to get those hairs to start growing again and duplicate. You don't actually, if you have a room full of hairs, those hairs weren't actually on your head ever. There was one hair, and that eventually died. All of the rest are going to be just derivatives from that. And so it's a similar thing for the AstraZeneca vaccine with that HEK 293 cell line. For the cell line that's used by the J&J, Johnson & Johnson, or some of you might have also heard it called Janssen, so Janssen. Again, that's a Dutch word, so it's pronounced Janssen. They use a different cell line that's called the PER-C6 cell line. Again, it's going to be embryonically derived. This particular, this came from a fetus that was aborted in 1984 or 85, I can't remember which. And we don't have any of the details surrounding that abortion as to why it was the mother's life at risk, or was it strictly elective, or what the scenario was. What we do know is that the fetus was not aborted for the purposes of scientific experimentation. Okay? I think that's an important designation. Okay? So we have cell lines that are used to grow these viruses. The viruses don't actually contain fetal cells, but the viruses were originally grown in fetal cells and then removed from those cells. So, or I should say, fetally derived cell lines. And those cell lines did not originate because a fetus was killed for the name of science. So the way that I always kind of liken it in my head to is there's a big difference between shooting someone and taking their organs versus taking someone who was shot for some other means and then harvesting the organs to save somebody. So the direct cause and or the reasoning behind that cause and effect relationship is pretty important. If you a couple of religious organizations have made statements on this. So the Southern Baptist Ethics and Religious Liberties Commission stated that it's because of the distance, so because these cell lines were taken back in the 1980s, and because they weren't harvested for the purpose of making vaccines, and because no other fetuses are going to be aborted in order to keep making these vaccines, it's okay to use them. The Catholic Church made a similar statement, and they went, the U.S. Conference of Bishops went a little bit further, and they said receiving a COVID-19 vaccine ought to be understood as an act of charity towards other members of the community. In this way, being vaccinated against COVID-19 should be considered an act of love for neighbors and a part of the moral responsibility for the common good. Given the urgency of this crisis, the lack of available alternative vaccines, and the fact that the connection between the abortion that occurred decades ago and receiving the vaccine produced today is remote, inoculation with the new COVID-19 vaccines in these circumstances can be morally justified. I should note that there was also another statement that was released by the U.S. Conference of Catholic Bishops that essentially kind of qualified that a little bit, and they said for members of the Catholic Church, if you can receive an mRNA vaccine instead of one of the viral vector vaccines that was grown in fetal cells, then they would prefer that. But if you don't have a choice, just get whatever you can take. So that's kind of a long way of going about the answer, but to say, no, there's not any fetal cells in the vaccine, but there are fetally derived cells that were used to grow the vaccine, but no fetuses were aborted for the purpose of making these vaccines. Does that make sense?
Yes.
Okay.
Yes, it does make sense. Thank you for clearing that up. That's very thorough.
And while I got this slide up, one other thing that I just wanted to make sure that I stress as well is I told earlier that with the viral vectors, you do actually have DNA going into entering the nucleus of some of your cells. But in order for that DNA to become incorporated into your DNA, you need the virus would have to have a very special type of enzyme called an integrase. And there are some enzymes that have that, like HIV has that, so it can incorporate its own DNA into your cell lines. These viruses don't have that, so you're not going to be able to take any of that viral DNA and incorporate it into your DNA. It's going to be kept separate. Okay? So there's no viral integrase, so you don't have to worry about that. That's it. Keep going, Billy.
Cool. All right. We are running short on time. I'm going to go to just one more question. Folks, if you're leaving and you have to, I know we're at, goodness, what is it, 3:30, I left at 3:30. Please stick around. We got just a couple more things. But if you do have to go, I want to remind you to fill out an evaluation that you'll be prompted to do as you exit. But I wanted Peter and Joyce to get to this last question here about the sites have been shut down, and then also the pause. on distribution of Johnson & Johnson. So I'm going to put those two questions together. There was sites that were recently shut down that were doing J&J, and Asante, if you're still on the line, please jump in. But this is in the news today of recommending that the U.S. pause distribution of the Johnson & Johnson vaccine. Can y'all elaborate on one or both of these points?
I'll elaborate on the first point. From the public health perspective, we are following the CDC recommendation, and we've already implemented the pause on the Johnson & Johnson vaccine. So any currently scheduled Johnson & Johnson vaccine clinics will now be Moderna clinics. So that's our current status with respect to the CDC recommendation.
Did you guys see any adverse reactions when y'all did J&J for the time that you had it?
Not with respect to the adverse reactions that were discussed in the news with the blood clotting issues. We did not. Most of the same reactions that Dr. Kim discussed with the pain at the injection site and the fatigue, and some of the same reactions that we've seen in Moderna and Pfizer were the ones that we witnessed in Johnson & Johnson.
Okay. Awesome. Thank you.
I think that, I was just going to say, I think it's encouraging that government officials are quick to shut down sites anytime that there's a question about possible safety issues. That's showing that the system's working the way we want it to work. If there's any question, we want things to just say, okay, let's take a pause, reassess, make sure that this is going the way it wants. A few days ago, actually last Friday, I think it was, there was a site in Georgia that was shut down, that it was administering the J&J vaccine. That was actually due to a different set of circumstances, where that was at some of the fairgrounds, and some of the individuals were getting dizzy, nauseated, had nausea, lightheaded. I think one might have fainted. Currently, people think a lot of public health individuals believe that that's just due to the hot weather at the fairgrounds today. But they shut it down just to be safe. What we're dealing with today, with all the headlines today, just like Dr. Hiltz mentioned, this has to do with a special type of blood clotting. Joyce, do you want to tackle this, or you want me to?
Why don't you start, and then I can pick up wherever.
Okay. Can you, Billy, can you skip down maybe a couple of more slides? Beautiful. Okay. So this morning, the FDA recommended that states put a halt on administering J&J vaccines out of an abundance of caution. And the reason they did that is because out of the 6.8 million doses that have been administered, they were able to see 6 cases of rare and severe blood clots. And this was reported in women between the ages of 18 and 48. One woman died, another is in critical condition, and these symptoms occurred between 6 to 13 days after vaccination. Because of this, the CDC is going to be holding an advisory committee on immunization practices this coming Wednesday, so tomorrow, just to review these cases and their potential significance. And they put a pause on the distribution of the J&J vaccine because this particular potential adverse side effect is not listed or was not disclosed in the emergency use authorization. So again, they don't want to be distributing a vaccine if everyone doesn't already know what the potential side effects are. Also associated with that is that this particular type of clotting incident that we see is really similar to what you can see in some rare cases of where you can administer heparin over longer periods of time to older patients, usually over the age of 50. And what you can see there is it's called, well, what we see in these patients is cerebral venous sinus thrombosis. So you can get some blood clots in the brain's venous sinuses, and that's going to prevent blood from draining out of the brain. It could be really, really dangerous. But this is this particular flavor of it is associated with thrombocytopenia. is associated with thrombocytopenia. So it's thrombosis with thrombocytopenia, meaning that there's actually a low level of platelets. And that's what you every now and then can see when you administer heparin, which is an anticoagulant over long periods of time. You can see a very similar thing happening. And this is the same kind of side effect that's actually being seen with the AstraZeneca vaccine in Europe. And one of the reasons, again, why they're pausing on this is because if it was just blood clots, it wouldn't be quite as important. Well, I don't want to say quite as important, but this is a little bit more nuanced, because if there were just blood clots, you could administer heparin as a way of treating it. But because this is thrombosis with thrombocytopenia, you can't administer the heparin. And so, again, they needed to have a pause just so they can educate a lot of medical providers on, hey, if you see blood clots after someone gets the J&J vaccine, don't use heparin unless you've already looked for particular types of antibodies that are present. The reason why this comes out, we don't certainly know the cause, but based on the mechanism of action for the heparin-induced thrombocytopenia, we can speculate on the cause. So what happens with heparin is heparin itself is going to be this big negatively charged particle, and it's able to, once you give it over too long of a period of time, it can cause your body to produce a type of platelets called against platelet factor 4. So these are anti-platelet factor 4 platelets. And when you get these things all together, they end up forming these, it leads to the formation of clots. Now, you don't have heparin in this case, but what they suspect is that for some reason, it could be due to chronic inflammation from the vaccine. It could be due to maybe previous infections with viruses or bacteria. They suspect that you have what's called cell-free DNA, which is DNA that's just kind of hanging out in your bloodstream. And the increased amount of this non-native cell-free DNA combined with the vaccine can set it off to make a clotting event. That might have been confusing, but one thing I want to stress is that this is very, based on our preliminary data, it's very rare. So again, over 6.6 million doses have been administered, and we've seen 6 cases of this. And out of those 6 cases, 1 person's died. Billy, if you can go to the next slide for just a second. I think it's useful to compare it to some of these other numbers. So here we're looking at the patients we've seen this in are between the ages of 18 to 49, 18 to 48. So if we look in that same window for overall number of deaths per million people from any cause, it would be about 1,686 people can die from some cause other than COVID, and 200 people out of a million would die from COVID in that age group from 20 to 49 years old. So here we have less than 1 person in a million. Really, it's about 0.1 person in a million has died from this adverse side effect from the vaccines. So you're still like 2,000 times more likely to die from COVID than you are to die from the vaccine. Based on the preliminary data. Again, this data could change once we get more data. But I think it's important to kind of keep it in perspective how small the numbers are. So they really are doing this out of an abundance of caution and not because it's a widespread event. Joyce, please take it over.
Yeah, no, thank you. I did want to clarify that in the Johnson & Johnson FDA briefing report that you went over, there was, and I think you may have talked about this, but there were events that were reported of blood clots. There was one of the sinus thrombosis that we're talking about, the blood clot in one of the major veins that crosses over the top of the brain. And so it was very rare in the study itself. I did want to clarify that the theory for it mimicking something called heparin-induced thrombocytopenia, which is just fancy words to say you have a low platelet count because your body's responding to a medicine improperly, is based off of the data from AstraZeneca. And it looks so really similar. And it's really kind of interesting from a medical perspective because you actually have low platelets, which platelets, you know, they're the things that form scabs and they form blood clots if they amass into one group. You have a low platelet level and yet you're forming blood clots. So why is that? I thought I had low platelets. Why am I forming clots? The way that it works is that there's an antibody that we can detect in the blood that stimulates the platelets. And so even the low number of platelets that you have are being activated. And as they activate, they sort of recruit each other, and then form blood clots. And so that's what they found in some of the participants when they've studied the patients who have had blood clots in Norway and in Germany. There were 2 studies that came out. Not in all of the participants, but some of them did have that antibody, and so they're thinking it's related to it. And I'm sure that those blood tests are going to be done in the Johnson & Johnson recipients as well. So yeah, we saw that news this morning and wow, what's going on? But that's sort of where we are with it, and hopefully we'll have more information to come. Yeah, after Wednesday, the ACIP is meeting on Wednesday.
We'll be staying tuned for sure. Thank y'all for fielding those questions. So we are at the last slide here. I want to thank you all for joining. I really appreciate Crystal and Yvette and the team from Three Rivers AHEC for putting this together and making this happen. Again, this will be recorded and shared online, so be on the lookout for that. As if you'd like to share this with your friends and family and whoever, your coworkers, we'd love for you too. I'm just going to read a little bit here. This activity has been approved for 1.8 contact hours, and so if you're on the call and this appeals to you, just be aware that is the case. Crystal, jump in at any point if you need to clarify anything. Three Rivers AHEC is an approved provider of continuing nursing education by the Alabama Board of Nursing. Your feedback is super important to everybody on the call or to the entire panel. We want to continue being a source of information for you. And so we want to hear from you. We want to know what you liked, what you didn't like. And so there will be an online evaluation for you to complete. When you leave the webinar today, in your browser, there'll be an evaluation link, and you'll also receive that in a follow-up email within 24 hours. And we'd love for you to complete that and fill it out completely so that we can have all the information that we need to make this stuff better. We are also open to any other questions or feedback you might have. We're going to aggregate those through Yvette. Her email address is on the bottom, and that's ypayton at threeriversahec.org. So I was thinking
Thank you.
about a way to summarize it. I don't think I could do it. Go ahead, Crystal. Take it away.
Well, you did such a wonderful job at moderation for us today. We are very grateful for your efforts. On behalf of the team and the entire organization, thank you to all of our guest speakers for taking the time out of your busy schedules to educate the individuals of our community about the vaccine and some of the hesitancies associated with the COVID-19 vaccination. And thank you to all of our attendees for hanging on. I know that we went over a little time, but it was great information. And I hope that you're able to take this information and share it with your peers, your colleagues, family, and continue the message. And that concludes the presentation today. Please feel free to share any other questions with Yvette. And please be sure to complete the evaluation because your feedback is so vital. Thank you.
Thank you.
Bye, everyone. Thank you. Thanks, Crystal.
Thank you.